If you are preparing for GPAT, NAPLEX, or OPRA, this part decide your rank. This is part 3 of the respiratory system series. In part 2, we already mastered nose, nasal cavity, pharynx, larynx, and trachea. And remember, questions from this area are direct MCQs in competitive exams. Now we are entering the most important and most asked section of the respiratory system, the lungs. From here, examiner asks anatomy and lobes, alveoli, type 1 and type 2 cells, pulmonary blood supply, disease-based MCQs. Miss this part, you miss easy marks. Watch till the end because I will connect anatomy with repeated GPAT questions, NAPLEX concept, and OPRA exam traps. Let's make lung anatomy easy and exam ready. Before we understand diseases, gas exchange, or MCQs, we must first see the lungs in your mind. The lungs are paid, spongy, and elastic organs placed inside the thoracic cavity, one on each side of the mediastinum, the central compartment that contain heart, blood vessels, trachea, and esophagus. So the lungs are placed around the heart, not above or below it. So oxygenated blood can be delivered immediately and efficiently to the heart after gas exchange. So many people think that why lungs are spongy and elastic in nature? So the lungs are described as spongy because they are filled with millions of tiny air sacs called alveoli, and they are elastic because they must expand during inspiration and recoil during expiration. Most people will think, what is inspiration? Inspiration means inhale of air. What is expiration? Expiration means exhale of air. What is mean by recoil? Recoil means coming to the same position. This elasticity is essential for normal breathing without extra energy expenditure. So, if there is no extra pressure for breathing, so if there is a loss of elasticity, we can see in the diseases like emphysema. So, remember this for the exam point, that loss of elasticity is seen in the diseases like emphysema. No, most of the students think that how the lungs are covered. Okay, so the lungs are covered by a pleura, which is a doubled layer serous membrane, which is called pleura, which reduces friction during breathing. This pleura is having a two layers. So the first layer is called visceral pleura and the next is the parietal pleura. So based on the position, the visceral pleura is tightly adhered to the lung surface, whereas parietal pleura is lined to the thoracic wall. So in between there is a space called pleural cavity, which is filled with a thin fluid which acts like a lubricating oil, which acts like a lubricating oil, allowing the lungs to glide smoothly against the chest wall during respiration. So, remember that if there is a fill of air in the pleural cavity, which leads to a condition called pneumothorax. So, guys, now so many students will think the shape of lung, why it is conical. So, each lung is cone shaped, which is perfectly fit the shape of the thoracic cavity, apex and the base point. So apex means the top point which points upward above the clavicle, and the base is the broad and the rest on the diaphragm. So this design allows the lungs to expand downwardly efficiently during inspiration when the diaphragm contract. We learn about the diaphragm. The shape, the shape of the lungs is conical shape. Now, so many students have a doubts like why are lungs light in weight despite of their large size? Because they are filled with air. Okay, so the right lung is lighter than liver side expectation, whereas the left lung is slightly lighter due to cardiac notch. For exam point of view, you have to remember that air filled organ with low density is lungs. And coming to the surface of the lung, to understand the lung anatomy, imagine how the lungs fit inside the chest like a puzzle piece. So based on the location, the surface is divided as costal surface, medial surface, and diaphragmatic surface. So, the costal surface, which means it faces the ribs and intercostal muscles, whereas which is a smooth and convex and adapt to the chest wall movement, and this surface expand and contract with rib movements. Okay, coming to the medial surface, medial, which means median, in middle. Okay, faces the heart and mediastinum, which contain hilum. Hilum, which means it is a point where entry and exit of bronchi, blood vessels and nerves takes place. So remember guys, this point for the exam as hilum location is equal to medium surface, medial surface, medial, middle. Okay, next is the diaphragmatic surface. So diaphragmatic surface is a concave surface which rests directly on the diaphragm. During inspiration, diaphragm will get contract and moves downwards, and the lungs will expand vertically. Okay, so that the air directly enter into the alveoli. Okay, so you have to remember, for this there is a clinical correlation. If this diaphragmatic muscle will get paralyzed, so if it gets paralyzed, there will be a reduced lung expansion. If it get paralyzed, then there will be a no contraction of the diaphragm, and there will be no movement, and the lungs expansion will be a very hard, so it will reduce lung expansion. Why this matter is exam for exam? Because understanding lung position and the structure help you to answer MCQs related to pneumothorax, pleural effusion, lung expansion mechanics, imaging, X-ray or CT, and surgical anatomy. So guys, remember this point like lungs are cone shaped, air filled organ wrapped in pleura, hugging the heart medially and ribs laterally and the diaphragm below. Lobes and fissures of the lungs. The right lung is larger and broader because it does not share space with the heart. Therefore, it is divided into three lobes: superior, middle, and inferior lobe. These lobes are separated by two fissures, named oblique and horizontal fissure. This oblique fissure separates inferior lobe, whereas horizontal fissure separates superior and the middle lobe. So, guys, in here the clinical correlation is right lung infection are more common because inhaled particles directly enter the right side more easily because it is a broader, and the right middle lobe syndrome is the place where recurrent infections due to the poor drainage. On the chest x-ray we can observe that fissures helps to localize pneumonia to a specific lobe. So exam point of view, you have to focus that only lungs with a middle lobe and only lung with horizontal fissure is right lung. So in the right lung, we can observe the middle lobe as well as horizontal fissure. Whereas in the left lung is smaller and narrower because the heart occupies the space on the left side of the thoracic cavity. To accommodate heart, the lungs has only two lobes and one fissure. So in the left lung, two lobes, one fissure. Two lobes are superior and inferior. And whereas one fissure is oblique fissure. So here the cardiac notch and linguala is present. Cardiac notch means which is where the heart rests, and linguala, which is a tongue-like projection of the superior lobe, is called linguala. So here the functionally the linguala corresponds to the middle lobe of the right finger. Here, the clinical correlation for the left lung is cardiac enlargement can compress the left lung, and lingular pneumonia mimics right middle lobe pneumonia, and the left lung is more involved in cardiac related respiratory system because the almost all the part of the left lung is covered to the heart. So heart is occupied on the left side of the thoracic cavity, left lung. So here all the cardiac related respiratory symptoms can be seen. Why this difference is seen? Because the heart lies on the left side, the left lung. Loss of space and loss of one lobe and develop cardiac notch. This anatomical adjustment ensure efficient heart lung coordination. So for the exam point, what you have to remember that Which lung has middle lobe? Right lung. Which lung has horizontal fissure? Right lung. Which lung has cardiac notch? Left lung. Which lung has linguala? Left lung. So remember this point. So, guys, up to this point, we have clearly understood the lungs, their position, structure, lobes, and clinical importance. This foundation is extremely important because without it, the next topic can be easily become confusing. Many student gets overwhelmed when alveoli and blood supply are explained together in one video. That's why I am not going in depth right now. I want you to understand step by step, not memorizing blindly. In the next part, we will focus only on alveoli, type 1 versus type 2 cells, pulmonary blood supply, clinical correlation, and repeated MCQs from GPAT, NAPLEX, and OPRA. If you want to truly understand gas exchange diseases like RDS and pulmonary embolism, and score easy marks in exams, don't miss the next part. Subscribe, save this video, and turn on notification. Part 4 is coming very soon.